Namaste. I am Manaswini Keshav and I will be presenting my e-poster on the topic Influence of Respiration and Position on the internal jugular vein dimension in cardiac surgery. I chose this topic as IJV catheterization is the bread and butter of every cardiac anesthetist. Ultrasound-guided IJV cannulation is the standard of practice in cardiac anesthesia. Compared to traditional landmark techniques, ultrasound-guided IJV cannulation improves the patient outcome by increasing success rates and reducing complications such as carotid artery puncture and pneumothorax. We conducted a study to investigate the dimensions of the IJV, keeping certain parameters in mind that I'll talk about, and in turn finding the efficacy of the use of Trendelenburg position during catheterization. Did it prove more efficacious? Let's find out. A prospective cohort study was conducted and the dimension of the right IJV was assessed in 42 adult cardiothoracic patients using a two-dimensional ultrasound. Visible pulsations of the carotid artery and the compressibility of the IJV helped us differentiate the two. The picture attached here is the visual we obtained on placing the transducer at the level of the cricoid cartilage on the right side of the neck. To avoid compression of the IJV, there was minimal pressure exerted by the transducer device of the ultrasound. The maximal anteroposterior diameter and the transverse diameter of the IJV were measured in 15 to 20 degree Trendelenburg position and in supine position during spontaneous breathing before anesthesia and controlled ventilation after anesthesia. The tidal volume after intubation was targeted at 6 to 8 ml per kg body weight. All 42 patients were cannulated by consultants and done in head-low position, and all cannulations were effectively done in the first attempt. After tabulating the findings and identifying the mean and its standard deviation, we found out that the dimensions of the IJV were significantly greater when the patient was awake and expiring in Trendelenburg position compared to other positions during the awake state, and in inspiration and controlled ventilation in an anesthetized patient in Trendelenburg position compared to other positions during the anesthetized state. From the graphical representation of the findings, we noticed that the dimensions I just mentioned were the largest compared to others in the category. We concluded that the IJV access is best done in the position during the respective respiratory cycles that I just mentioned. If an ultrasound machine is unavailable, we suggest that cannulation of the IJV is done in the head-low position in an anesthetized patient on controlled ventilation during inspiration. This should increase the success of cannulation if we are using an approach based on anatomical landmark technique. Based on anatomical landmarks. This is what we concluded in the study. I would like to thank Dr. Kanchi, Dr. Bilani, and Dr. Bhimaya for their support and guidance, and Narayana Hrudayalaya for giving me a wonderful platform to successfully conduct the study. Thank you.